I'm Nick Mayenza. I'm the ultrasound fellow here. And I will be with you guys when we come back from our ultrasound conference in Texas. So like later this week, next week, you'll see plenty of us a bit more. But today we're going to be talking about thoracic ultrasound and the Blue protocol. All right, so objectives, we're going to talk about the anatomy of pretty much of the thorax a bit. We're going to be talking about artifacts because artifacts play a big role in thoracic ultrasound. We're going to talk about how you actually do the ultrasound, and then we're going to get into the nitty-gritty about the blue protocol, which is like the protocol you do for a blue patient, for a respiratory distress patient. And we'll talk about like the main pathology associated with the blue protocol. All right, we will jump to this in a little bit, but this is the actual blue protocol, and we're going to go very in depth into this later on. All right, so the anatomy. So we're keeping it really simple, starting from the beginning. Obviously, there's skin, there's subcutaneous tissue, there's some muscle layer. Then you get down to like the actual rib cage, and you can see the lung underneath the rib cage. I know you're all physicians. This is super straightforward. Just it's important to like hammer home that the ribs are over the thorax, over the lung, because that plays a big role in lung ultrasound. All right, so you take the ribs away, then you've got the parietal pleura and the visceral pleura. So you've got that parietal pleura on like the outer chest wall, and then on the visceral pleura, which is like actually around the lung. So you've got two separate pleura. Again, also very important. And then right in between them, you have that pleural space. It's not actually this big. Um, can you see my mouse moving also before I go any further?
Yes.
Okay, perfect. So yeah, you have the pleural space between the parietal pleura and the visceral pleura. It's not actually this big. It's really just like a non-existent space, but there is space between them. All right, you go further down beneath those pleura, and then when you have like the actual lung, the lung breaks down from the like right and left bronchus to the bronchioles to the alveoli, and then these alveoli are like grouped together and like anchored down by this interlobar septa. And this interlobar septa is actually the thing that's like anchored to the visceral pleura. So that's super important when we talk about like certain pathology, where there's like any kind of infiltrate, or if there's like edema, if there's anything in this interlobar septa, that's actually what we're looking at when we're looking at like actually looking at the lung with the ultrasound. All right, so some basic ultrasound review. Sorry, I thought someone else was trying to join. All right, so basic ultrasound review. As far as like your grayscale, you've got, thank you, anechoic, you've got hypoechoic, isoechoic, hyperechoic. So anechoic, remember, is something that is black. It's going to be things like blood, urine. So any fluids are going to be black anechoic. And then on the other end of the spectrum, things that are very dense that are going to be reflecting more and more sound waves are going to be hyperechoic. So this is stones and bones. And then specifically for like ultrasound, it's going to be like bone, so it's going to be the ribs. While anechoic, it's going to be something like a pleural effusion if we see it. And then in between, we have that 256 shades of gray. All right. We've got our gallbladder here. This is just an example of a couple of different artifacts and actual like grayscale itself. So you've got your liver right here with your gallbladder. So your gallbladder is anechoic black. You've got this stone right here, which is very dense. It's hyperechoic. And then you have some shadowing underneath it. Sorry, let me just make sure everyone's able to join the meeting. There we go. All right, so now some artifacts. I know we just talked about it before, but you had that image of the gallbladder with the stone within the gallbladder. So first artifact is shadowing. Just remember, shadowing is when you have something that's very dense. No sound is going to be able to penetrate through it and past it. So because of that, you have this like big shadow that appears beneath that stone. So another example we always give is picture you're standing in like a pitch black basement. and there's a pole in the middle of the room, and you're taking a flashlight, which is ultrasound beam, so you're like scanning side to side. The moment you hit that like post in the middle of the like pitch black basement, none of the light is going to go beyond it. So the light will light up the entire basement except when you hit that post, and that post won't let any light go beyond it, so you get that shadow. So it's the same concept, but instead of a flashlight, you're using the ultrasound that's going down this way and creating this shadow down here. All right, some other artifacts that are important. You have mirror artifact. So mirror artifact is you have something that is very reflective, and you create an image of like a duplicate image on the other side of a really reflective surface. So for this one, it's you're creating another image of a liver on the other side of the highly reflective diaphragm. So just to orient everyone, you have your kidney right here, you've got your liver, got this little hemangioma here, and then you have your diaphragm. So ideally, in real world, or in a real world, in like a non-artifact image, you have your diaphragm right here, and then like nothing above it. You don't see anything. It's just normal aerated lung. So with this artifact, sound waves are coming down, down, down. They're hitting the diaphragm and then going back to the ultrasound probe, which generates this image of this diaphragm. Other sounds going down, 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 hitting this hemangioma and bouncing back and doing the same thing. And that's how you get this image of like the liver and the hemangioma. But mirror artifact is when the sound waves go down, 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 hit this really reflective diaphragm, and then some of the sound bounces off and then hits this hemangioma and then goes back. So what it does is it creates like an image of the liver on the opposite side of this diaphragm. So it's just important to know because this could easily look like a possible consolidation and look like a really bad pneumonia, but in reality, it's just artifacts. All right. These are the ones that are really important for lung ultrasound. So you've got your A lines. So A lines are just like normal aerated lung. Basically, sound waves go down from the transducer. They hit this visceral and parietal pleura. That's what we're looking at right here, this bright white line, that visceral and parietal pleura. So sound waves go down from the probe, hit that pleura, and then bounce back to the probe, and that generates that image of that visceral and parietal pleura. So A lines are these like repeating lines underneath. So like right here, right here. So what happens is sound waves will go down, another sound wave goes down, hits that really reflective visceral and parietal pleura, bounces back to the probe, and then bounces back and forth a second time and creates the second image right there. So it's kind of like a feedback loop. So the number of times the sound gets stuck in this like cycle. So if it bounces back and forth twice, you get the second line. If it bounces back and forth three times, you get the third line. So these repeating lines down here, 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 all the way down to the bottom of the screen, those are just normal A lines. Those are normal, just aerated lung. It's just like that feedback loop of sound getting stuck between the transducer and the pleura. All right, next we have two reverberation artifacts. The first one is comet tails. So this is an example of a comet tail within like a blood vessel. So this right here is a blood vessel, and then inside of it is a needle. So comet tails already have two highly reflective surfaces close to each other. Sound waves can go down, get stuck in between those two high reflective surfaces, bounce back and forth, and create this like short little white tail right here. So what you're looking at right here is actually a needle inside a vessel, and sound wave is going down and like hitting like the little bevel within that needle and bouncing back and forth and creating this white line. So that's what that comet tail is. Another reverberation artifact, and probably like I'd say like one of the most important ones for lung ultrasound, is B lines. So B lines are when sound goes down from a transducer. So the transducer right here goes down and it goes into a little pocket of fluid that's surrounded by air. So when ultrasound hits air, it kind of like scatters everywhere and it's very reflective. So it just kind of it doesn't like direct the sound like a specific way. It kind of reflects it every direction. So when sound waves goes down and hits this pocket of fluid that's surrounded by air, when the sound tries to leave this little area, it hits this air pocket and gets reflected, hits this air pocket and gets reflected, and kind of like just bounces all around. And that sound that gets stuck in this fluid pocket and just bouncing back and forth creates this big rain down artifact. So if you have like a little pocket of fluid surrounded by air right here, you have this big white line that goes to the bottom of the screen, and that's what a B line is. So for like lung ultrasound, If you have something like pulmonary edema, which we'll talk about in a bit, you have like fluid in the interlobar septa. So you have like fluid surrounded by all that air. You get these bright white lines shining down from the pleura. All right. So how are we going to actually perform this ultrasound? So there's a couple different ways to do that. Ways to do it. I'll talk about like for the most part, like the different like protocols, the different like stepwise approaches to do it. For the most part, we're going to be in the ER. You're going to be ultrasounding people who are like laying in a stretcher. So you're going to have the patient laying down. They could be sitting up, but for the most part, just laying down. And you're going to be going to a couple different spots. If you want to like optimize and get like a little bit of better picture of the lung, you can have the patient raise their arm. So whatever side you're standing on and whatever side you're scanning, try to have them raise their hand above their head to like kind of spread those like intercostal spaces and get a little bit of a better look through through the ribs at the lung. So this is just a breakdown as far as like what you're looking at. So like depending on where the probe is, it's going to depend on like what portion of the lung you're looking at. So obviously like upper on like either the right or left, you're going to be looking at right upper. Like posterior, you're going to be looking at like the lower and the upper, depending on where you are. And then the right depends. You could be getting right middle lobe or right lower or right upper. But just like a rough guide as far as like what part of the lung you're looking at. So as I said before, we're going to be doing this on ER patients. So we're going to be doing, for the most part, like a anterior superior, like a posterior, like lateral, and like an inferior lateral. So you kind of want to do like almost like anterior chest, lateral, and then like more inferior. Just because fluid can either like become very dependent in one area, a pneumothorax can be dependent over here. So just each area will provide you different information. So that's why we want you to look at like 3 areas on each side. So like anterior superior on the right, kind of like lateral on the right, and then inferior lateral on the right, and then kind of same thing on the left. And then just again, this all provides different information. So if you're looking just anterior, you're going to be looking at like just the anterior portion of the lung, like just the upper lobe of the lung. And that's why it's important to go not just like inferior, but go more lateral too. So you're getting at like the entire view of the lung. All right, so how are we doing this? You want your probe on the chest, and you want the probe marker pointing superiorly, so pointing towards their head. So no matter if you're on the anterior chest or the lateral or like the posterior lateral, you want the probe marker pointing towards their head so we can always like orient ourselves when we're looking at the images. And then when you're doing it, you kind of want to slide down. Like after you save this image, then you move down and you get the posterior and lateral views. All right. The reason I was harping so much before on like the importance of just like talking about the rib cage being above the ribs, the rib cage being above the lung, is that you need the ribs to like orient yourself when looking at thoracic ultrasounds. So when you're looking at a thoracic ultrasound, you need to see that visceral and parietal pleura. And if you don't see ribs to like orient yourself, it can be very confusing. Because it can be very easy to like see just like a layer of like fascia and mistake it for the visceral and parietal pleura. And like say you're like looking at someone with like a really thick chest wall and you see this like fascial layer and you mistake it for the pleura that's not moving, you could easily like get a false diagnosis. So it's important we again keep the probe marker towards the head. And when we're doing the ultrasound, you want to make sure that you're getting like one rib above and one rib below so that we can tell that the space in between is that visceral parietal pleura. And this is the image that we're actually getting. So you're getting a little bit of skin, like that ultrasound gel right here, this subcutaneous tissue, and then you're getting a rib right here with a big shadow, rib right here with a big shadow, a little bit of like intercostal muscle, and then this is where the money shot is right here. You're getting the parietal pleura, and then that little red space right here is that like pleural space, and then the visceral pleura. But there's really no space in between there, like when we're looking at real ultrasounds. So just visceral and parietal pleuras right here. And what does that look like on a real person? So again, rib with a big shadow, rib with a big shadow, and then we're looking right here at the visceral and parietal pleura. And this is why, again, it's important to have the rib and the rib and be able to tell and like use these as landmarks that show what you're looking at. Because if you didn't have those ribs and you like cut this image and just looked at like the middle part and you didn't see the ribs, it could be hard to tell if like this bright line right here is truly the parietal pleura, visceral and parietal pleura, or if like maybe this is it, or maybe this is it up here. So you need these ribs to serve as like an anchor to tell you that yes, I'm in the right spot. Yes, this is the correct line that I'm looking at. And then just a GIF version of it. So again, rib with a rib shadow, rib with a shadow, and then you're getting in between those ribs that visceral and parietal pleura. And at this point, this is when the patient's like breathing, and you're seeing that movement along those two pleura. All right, so I made this cartoon. I'm going to be using this throughout the lecture to kind of have like the most simplified version of like what pathology you're looking at. So again, rib, and then you would have a shadow here, and then rib with the shadow, and then you're looking at the parietal pleura and the visceral pleura right here. So again, when an ultrasound like is created, sound waves will come down through here, hit that pleura, bounce back to the probe, and generate that image of that line. It's important to note that anything below this, so sound waves that go beyond the visceral and parietal pleura in a normal aerated lung, so sound waves that go down on this yellow one, go down, 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 they go past the visceral and parietal pleura, they're just going to scatter and like attenuate. So they're just going to go everywhere. So in a normal, healthy lung where everything is aerated, there's no like pathology, there's no fluid, there's no consolidation, anything below this visceral and parietal pleura is just going to be like artifact. There's no actual like image being generated here. So it's super important to know. So again, anything below this line in a normal aerated lung is just going to be either artifact or it's like not something we're looking at. Feel free to stop me anytime because I know this is pretty early on in the rotation. All right, so now we actually have the blue protocol. So again, the blue protocol, it's just a protocol like that's in place for like if you had someone who's respiratory distress, and you went and did an ultrasound on them, like how you could kind of narrow down some of the more like critical diagnoses like pretty quick, just with like a pulmonary ultrasound. So first, we're going to start off with the left side of the right side of the graph. We're going to be discussing like lung sliding and all these pathologies. So lung sliding. So again, we have this cartoon. So what is lung sliding? You've got this rib with the shadow, and you have that visceral and parietal pleura. So every time that patient takes a big breath, that pleura on the viscera just goes back and forth and slides along that parietal pleura. So pneumothorax can occur if that visceral pleura is gone. Sorry, then there could be no lung sliding if things like a pneumothorax occur, like that other pleura is gone, like the lung is collapsed, or if that visceral pleura becomes like really thick and inflamed and becomes sticky and almost doesn't move at that point. So in a real image, this is again that normal visceral and parietal pleura shimmering and sliding along one another. And then right here, you can see this patient's like moving, like you can see their chest wall moving. But if you look along that visceral and parietal pleura, there's no like shimmering, there's no movement along that line. So this is someone who has no lung sliding. And then just side by side. So here along this line, it's not as like profound as the other one was. But if you look along this line, you see a little movement, this little shimmering along that line. And on this one, you don't see anything. If you're ever unsure, if just by looking at the actual like ultrasound, like that static B mode image, you can do M mode. I don't know if you guys talked about M mode yet, but M mode is motion mode. So you pretty much choose a point on the ultrasound image. So if you're not sure if you're seeing motion along that visceral and parietal pleura, you can do M mode. So you take this point, you can choose it, you can slide it over here, or wherever, but you take this line to this ice pick and you put it over the part of the image you want to look at. And what it does is it creates a graph over here, which is motion. So motion on this axis over time on this axis. So what it does, it's looking at motion along that line. So like say we choose this part of the line where this, what, see this little bit of fascia right here, this like white spot. So you can pick it up here, and that's what this corresponds to. And you say right here, if I look at that spot over time, there's really no movement. So the whole part is you can look at right here where the visceral and parietal pleura is, and that corresponds to this part of the image. And you see that like right here, over time, there's no movement. So this whole image is showing like there's no movement along this line over time. So this is what we call like a barcode sign. So this would be indicative of a pneumothorax. All right, so a normal aerated lung, normal healthy lung that has normal lung sliding, if you took that M mode and you put it over that visceral and parietal pleura, you would get this like sandy beach sign. So before, how we picked like that one spot up here and we looked and there was no movement, it's the same thing for this one. But if you look at the visceral and parietal pleura, so if you chose this spot, and in this spot, you see that anything below that area, there's movement. So there's like that shimmering movement along the line. So you get this like speckled pattern. So this is what we call like a sandy beach appearance, where like you're sitting on a beach and you're looking at the water. So this, all this movement down here is showing that there is movement along that pleura. All right, so that's actually what lung sliding is. So remember, lung sliding is just that movement of the visceral and parietal pleura. You can have no lung sliding if the visceral pleura is like really fat and thick and like sticky, like it's infected, or if that pleura is just gone and from a pneumothorax. All right, so the first diagnosis we're going to talk about is pneumonia. So you do your lung sliding, you evaluate for lung sliding, you don't see it. And then we're going to talk about B lines next. So you do lung sliding, you don't see it. So you can either have a pneumothorax or you can have a pneumonia. At that point, you look at B lines. So we'll discuss B lines again. So B lines, you have that interlobar septa, which is like affixed to that visceral pleura. So if that interlobar septa has like a lot of fluid in it, either from like pulmonary edema or something like a pneumonia, where it's just like or like a consolidated fluid, you have fluid built up along that line, and what that creates is those B lines that we talked about before. So these are B lines. So again, you've got that visceral and parietal pleura, and you have these big white lines that are shooting down from that pleura where that fluid's collecting, that are creating this like big reverberation artifact. So that's just saying that there's fluid in that interlobar septa. And there's more examples as we get more and more. So like over here, there's a couple B lines and there's more. And then there's like a ton right here, and they're like becoming confluent. So instead of like one single line, they're like kind of like grouping together and almost look like spotlights shining down. So you're doing your blue protocol, you evaluate for lung sliding, you do not see lung sliding, but you see B lines, that's telling you have a pneumonia. Another thing to note is if you do have B lines, let me just go back a couple slides just so I can, so if you have B lines originate from this visceral pleura. So again, that visceral pleura is where the interlobar septa is anchored. So if you go and you do an ultrasound and you see no lung sliding, but you see B lines, what that tells you is that even though there's no lung sliding, the visceral pleura is adhered to the parietal pleura, because that visceral pleura is where the B lines are generated from where the fluid is pretty much collecting. So if you look at a static image and it tells you, so like say you looked at this image and someone asked you if there's lung sliding or not, or if there's a pneumothorax or not, you could confidently say that there is no pneumothorax because there's B lines. You could say that these B lines are generated from that visceral pleura touching that parietal pleura, but it's filled with fluid. So it tells you that the lung is normally, and it's normal and inflated, but there's some other pathology, aka like it's like inflamed and sticky, it's infected. All right, so we did lung sliding, no lung sliding. We found B lines throughout, so we said this is a pneumonia. What happens if we don't find B lines? We just do an ultrasound and we don't find lung sliding on one side. Then we go to evaluate for a lung point. And that's where we're going to discuss pneumothorax. So again, this is normal lung sliding. So this is that rib right here with the shadow, rib right here with the shadow. And then along that visceral and parietal pleura, you can see that little bit of shivering. So right here, you have that sandy beach and that barcode one more time. And then right here, give everyone a moment. I won't call on anybody, but just like think about it. Think about, does this look like a sandy beach or a barcode? This is a barcode. So this is a pneumothorax or no lung sliding. This is right here. Think about it again. It's that sandy beach appearance. So there is normal lung sliding. Another example. This is another sandy beach. So normal lung sliding right here. So you looked for B-lines. Sorry, you looked for lung sliding. You did not find it. You looked for B-lines. There was no B-lines. So this tells you that like we're concerned for pneumothorax at this point. So our next step, as I talked about before, is finding lung point. So what is lung point? Lung point is pretty much the transition point from where pneumothorax meets no pneumothorax. So if we were looking at this person with a pneumothorax with their ultrasound and we looked up here, we would see no lung sliding. If we look down here, we would find normal lung sliding. So lung point is this point. So it's that transition between pneumothorax and then normal lung sliding. So this, if you find lung point, that tells you 100% that this is a pneumothorax, because there are other pathologies besides pneumonia and besides pneumothorax that can cause the patient to have no lung sliding. So to truly say that I'm confident that this is a pneumothorax, you need to find that lung point, that transition point. And then my wonderful animation. So this is your patient. You have the rib, the parietal pleura, and the visceral pleura. So lung point is when half of that pleura is gone, and you're just looking at that one area of lung. So this is the pneumothorax, and this is the normal aerated lung, and you're finding that pleura kind of slide in and out. And this is like another cartoon image of it. So pneumothorax right here, and then this is where the normal visceral and parietal pleura are still like adhered to each other. And the lung point is just like this point right here that slides in and out. And I also really like this image just because this shows that, again, the visceral pleura, if there's fluid in the visceral pleura, that's what generates these like comet tails or the B lines. So if you looked over here, there would not be any B lines, there would not be any comet tails, but over here there could potentially be. So remember, if a lung is normal, if the lung is inflated, then you can have B lines. All right, so how do you actually find a lung point? So say you are scanning this patient and you looked up here at like the most like dependent portion, like air dependent, meaning like air will rise. So you looked at like their chest and you looked right here on their chest and you found a lung point. What you want to do is you want to slide inferior and posterior to find that lung point. It's important to slide posterior to find that lung point, because if you slide just inferior, you'll eventually find the diaphragm and you might like mistaken like the diaphragm, like the diaphragmatic curtain as a potential lung point. So if you find if you find no lung sliding down here, up here, you want to slide lateral and posterior. So what does an actual image of a lung point look like? Just right here. So you've got rib, and then you've got your parietal pleura on top. And you can see right here, the visceral pleura is only sliding from like this point on. Right over here, there's no lung sliding. So this is lung point. That's that transition point. And this is like just like a beautiful example of it, where you see like no movement. You see the patient take a big breath and that lung slide in and out of frame. A couple more examples. All right, so Ken, you look for lung sliding, you did not find it. So then you were looking for B lines. you found B lines that told you that the lung is inflated, but there's another issue with the visceral pleura. So this is pneumonia. You didn't find lung sliding. You didn't find B lines, and you evaluated for a lung point. So you found that transition point, and that gave you the diagnosis of a pneumothorax. So what happens if you do look for lung sliding, you don't find it, you don't find B lines, and you also don't find lung point? That's where the question marks in this like whole protocol come into play. Because there are some other pathologies that we can't really evaluate for with ultrasound. That could have like all of like these negative findings. So things like patients having like a history of like a pleurodesis where like they adhered the visceral and parietal pleura together, or patients who've got like massive blebs. They can also have like they can also have like no B lines and no lung sliding potentially. So this is where like the question marks come into play. It's just telling you you need to do other diagnostic tests, like possibly do like a CT of the chest, like possibly do an X-ray, or just like do some other diagnoses to see if you can figure out what's going on. So again, if you don't find lung sliding, you don't have B lines, and you find lung points, pneumothorax. If you don't, just go down that algorithm, go down like a different pathway and like do further testing or like do a further, like do more history on this patient. All right, so that's that one half of the algorithm. Now we're going to talk about the other side. So say you go do this algorithm and you find lung sliding, then at that point, you're going to look for B lines. But this point, instead of just saying yes or no to B lines, you're really looking at like, are there no B lines? Are they both sides or are they on just one side? So again, you have your visceral and parietal pleura sliding back and forth. Then you're looking at B lines. And are they negative? So are there no B lines? Are they both sides? Or are they just on one side? So first we'll talk about pulmonary edema. So pulmonary edema, you look for lung sliding, you find it, you look for B lines, and they're just everywhere. Then you have your diagnosis of pulmonary edema. So this is just like a spectrum of like B lines. So right here, normal lung ultrasound, you have these normal A lines. You're not seeing any like big white like vertical lines going down from the visceral and parietal pleura. Right here, you have like one or two, maybe like three popping into view. So three or more B lines in an intercostal space is positive. So that's a technically positive exam. And then you have like way more where these are like confluent. Again, this is like a big spotlight. So even though this doesn't look like a single beam coming down, this whole thing right here is like almost like a spotlight shining down. So that's like a confluent B line. This is like more severe pulmonary edema. And say the patient's pulmonary edema went from really bad to like it continued, and they can eventually get a pleural effusion. So say you're looking at that like posterior lateral view, or you're almost doing your fast view where you're looking like above the diaphragm. At that point, you can get fluid around the lung. So this is just you're doing that like posterior lateral view, and instead of seeing like rib with like that little visceral and parietal pleura up there, you see this whole like fluid, and that's like compressing that lung right there. Or this is like another view of it where you're getting diaphragm and liver down here, and then you're getting like this little bit of lung that's like been compressed with all this uh, pulmonary edema right here and pleural effusion. And then just another picture because it's so satisfying to watch like the lung just like flop back and forth in the pleural effusion. And then I just want to talk about spine sign. I'm not sure if you guys talked about it during like the FAST exam, but spine sign. So remember, sound waves come down from the ultrasound transducer. Some of them come down, they hit this liver, and then they go down through the liver and they hit the spine, and they creates this image right here. But in a normal aerated lung, sound waves will go down, down, down. And once they hit this lung, they scatter and then pretty much creates this big black area right here where you don't see anything. So for this patient, if sound waves are going down, 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 and you're seeing the spine, it's telling you that there's something here that's allowing sound waves to be transmitted and go through it. So this is telling you that the fact that you can see the spine above the diaphragm, so you see the spine marching out up here, the fact you can see the spine above the diaphragm, that's a positive spine sign. That tells you that there's a big pleural effusion right there. And then there's some more images because they're cool images. If you get to the diagnosis, sorry, just silence this. So again, you looked for lung sliding, you found lung sliding, you look for B lines, the B lines were everywhere, you found pleural effusions. At that point, I would just take a quick look at the heart to like evaluate EF or not. Like if you come to the diagnosis of like severe pulmonary edema, you'd be concerned like this is like acute like CHF exacerbation potentially. So I would just like throw the probe on the chest. So that's not technically part of the blue protocol, just like I would do this just to kind of like confirm your diagnosis. Right. So that was pulmonary edema. That's just fluid everywhere in the lungs on both sides, fluid everywhere in the lungs, so bad to the point where like you potentially get like pulmonary edema, sorry, pleural effusions both sides. All right. Next diagnosis is just unilateral B lines. So this is pneumonia again. So you look for lung sliding, you find it, you look for B lines, and you just find them on one side. At that point, you say pneumonia. So pneumonia again. So say for this patient, you went and ultrasounded them, and this is their right side, and this is their left, and you see lung sliding on both sides, but you see B lines throughout here. That would tell me that for some reason, like there's a lot of pulmonary edema, or there's like a lot of fluid in the interlobar septa on just one side, and that would make me more suspicious for like an infectious process. Because it could happen, but it'd be very rare that you have unilateral, like cardiogenic related pulmonary edema. Again, it can happen, but more rare. So like if you just find unilateral, it's going to be more concerned with like an infectious process. So you look for B lines after finding normal lung sliding and they're just on one side. That tells me that this this one lung, the one area where I'm seeing like just these B lines is infected. All right. So now to not finding any B lines. So you look for lung sliding, you find it, you look for B lines, you don't find any. At that point, you kind of like do like a sidetrack from like a normal thoracic exam and you look for a DVT. So this is where like PE comes into play. So you perform a DVT exam. So normal lung sliding, no B lines, you're going to perform a quick DVT exam. So the way you do it, I know you can get in, we can get in like real depth into the weeds as far as like how to perform like a true proper DVT exam. But like the real easy way is like you pretty much just like take your probe, you put it like in the crease of the groin, you find the like femoral art, the femoral vein, and like you start up high and like you just compress and work your way down the thigh till you go behind the knee. But basically you take the probe, you have the patient stay laying flat. You do that like frog leg position where you have them externally rotate and like flex the knee a little bit. And you're looking from up here from the like common femoral vein within, and you're like working your way down here. And you really only have to look at like these couple points where the common femoral vein and the great saphenous vein kind of split. You look at the femoral vein and then popliteal vein. What you're doing is you're just like finding each of these points and you're finding the vein and compressing it and making sure that it's collapsible. So this is just like working your way down. This is like where the trifurcation, the bifurcation is. Then you eventually get to like the popliteal right here. So again, you're just working your way down. You're finding the vein up here and you're just like going down the leg, compressing as you move down, making sure that vein is collapsible. To see this patient, they go to do it and they compress and it's not compressing. So this would be a positive DVT exam. So this patient's severe respiratory distress, there is normal lung sliding, there's no B lines, and you perform a DVT exam and they suddenly have this new DVT that was never known about, then I would go with the diagnosis, like the most likely diagnosis of like a PE possible PE. So what happens if you do that whole exam, you do the whole DVT exam, and then you don't find a DVT, at that point, you're pretty much like looking directly for a possible pneumonia. So pneumonia for the third time. So pneumonia comes up a lot of times in this algorithm. So we talked about pneumonia being either like just like a visceral pleura that's like not moving, but with a ton of B lines, or a pneumonia potentially being a lung sliding that's normal, but just unilateral B lines. The other things you can get are like consolidations. This is like an actual pneumonia that's like butting up against the visceral pleura, and you're actually looking at the consolidation. So this is like a subpleural consolidation or like a massive consolidation where like the lung like looks hepatized. Or you can also just look and see if like the visceral and parietal pleura is like really jagged. So these are other findings for possible pneumonia. So right here, you're looking, this is like that lower inferior view. So you're looking right here and you're seeing this consolidation where this section of the lung almost looks like a liver. We can call this like hepatization. So this is like actually looking at the ultrasound and like just seeing a pneumonia, like seeing a big infected area of lung right there. And then just another one. So again, you have this diaphragm right here in the liver, and then this just looks like another liver on top. But it doesn't look exactly like a mirror image. So you're be a little bit more comfortable saying this is not mirror artifact. This is just like a massive consolidation. So this is a fake out. We talked about this kind of image before, where like you have this little hemangioma, and you can also see this blood vessel up here um, on this liver, and then you have this diaphragm right here, and then you can see kind of like the mirror image where you're getting that like hemangioma, this blood vessel, and it's just another flipped image. So this, even though it looks like a consolidation, this is mirror artifact. Another thing to help you determine if this is mirror artifact or a true consolidation is that spine sign we discussed before. So this patient, even though they don't like the other patients we had mirror artifact that had that like very convenient hemangioma, not every patient has one. So if you do this ultrasound and you see like what looks like a possible consolidation up here, but you're not seeing the spine, so there's nothing that's like dense enough to help transmit sound waves, but you're concerned this is a pneumonia, this tells you that this is more just mirror artifact because this thing that you're seeing up here is one, a mirror image of that, but it's also this thing you're seeing here is not transmitting sound waves, thus you don't see the spine sign. All right, so again, it's a diaphragm, this is liver, and this is a nice consolidated lung. And what we're seeing right here is a dynamic air bronchogram. So this is just like that big infected lung, and this is like some air that's like stuck in that infected lung. And when the patient breathes, it's like kind of like moving up and down. So you're just seeing that like little reflective piece of air in that infected lung that's kind of going up and down as that patient tries to breathe through the big infected tissue. All right, so those are all consolidations. At this point, we're getting into like subpleural consolidations. So like AKA just like tiny little areas of infection just underneath the pleura. So this image is all just like, again, this is just rib, and the patient, they're sliding their probe up and down. And what we're looking at is that visceral and parietal pleura sliding back and forth. And like in certain areas, you see this like big, the technical term is a big little goober stuck there that's just sliding back and forth. So this is subpleural consolidation. This is another form of another sign for a pneumonia. Kind of same thing. Call this the shred sign, where like the pleura looks like very shredded right here. But like in the beginning, you can see beginning part of the clip, you see like the visceral and parietal pleura, and it looks very clean. And as we move down here, it looks like very shredded apart, and then it eventually turns into like full hepatization, where it looks like a liver down here. Just want to watch it one more time. So in the beginning, normal visceral parietal pleura, and then there's subpleural consolidations. The pleura is like shredded apart, and then you get down here where this is like true hepatization. This is like a beautiful image of like the whole spectrum of pneumonia. And just like another nice consolidation right here. And then just like another one where this just looks very much like a liver. This just looks like a terrible lung. and another one. All right, so again, we did lung sliding. You looked for B lines, you didn't find any. We did a DVT exam, it was negative. And then we were literally just looking for pneumonia. We were looking for that consolidation, for that pleural irregularity, or we're looking for that subpleural consolidation. And we didn't find any of it. At that point, you probably should also have done a physical exam. At this point, you're going with like a possible diagnosis of like COPD or asthma. But again, this is where like you should also, besides just doing a pulmonary ultrasound, you should like listen to the patient. Like if they sound like COPD exacerbation, treat them as such. But yeah. All right, we'll do a quick case and then we're actually done. So say this patient comes to the ER or like they're on the floor and I forget the actual prop for it. You do the ultrasound, you find this on one side. You see this on the other. You keep scanning, you find this. I'm not sure if there's any other images with this, just because I don't remember how many pictures I put with the case. But anybody have any ideas? So I'll go through again. If we just go through the algorithm in our head, you can see that there's B lines here. There's a ton. You can see that there's lung sliding. So say this is the patient's right. There's lung sliding on the right. This is the left. There's normal lung sliding on the left. So that tells me that we're already on that on that left side of the diagram of the algorithm. So
It's pulmonary edema because it's B lines in both sides.
I would say, so if this was the other side, so you can have like little bit, I'd say like maybe a couple comet tails, maybe a little bit, but I'm not seeing any like real tall B lines. So comet tails and B lines can be confusing because they are both like vertical lines right here, but B lines truly like are lines that start here and like go all the way to the bottom of the screen. A little bit more like, I know this is like an extreme example, but like over here you see like a more single B line that starts here and goes down. I would say this looks more like a unilateral B lines to me. But so this would be like a patient who has lung sliding both sides. It looks like unilateral B lines, which technically gives us the diagnosis. And then you also keep looking and you see this, which is like a little bit of pleural
Pleural.
fusion right here. What was that?
Uh, would that be a pleural consolidation? What's below the fusion or no?
Yeah, exactly. So this is so this is like an effusion right here between that like visceral and pleura, and then this is like a nasty consolidation. This is like another big pneumonia right here. Yeah, exactly. So say this patient, you were like ultrasounding them and like this is what you see on like the apex. Like you see like a ton of like B lines, and then you looked at the other side and it was normal, and then you just like went back to that side that had B lines and you like went like inferior and you saw this effusion with this big consolidation. That will just like be like a slam dunk saying like, yeah, at first I was suspicious for pneumonia when I saw the unilateral B lines, but now I see this pneumonia. I can see the consolidation, and like kind of like I can hang my hat up on this diagnosis of pneumonia. Yeah, so like this case would be like a patient with a possible pneumonia. I think that's it. So again, this is the blue protocol. So think about this. If you have someone who has shortness of breath, respiratory distress, for all of you IM people, if you're on the floors and you like respond to a rapid response, feel free to whip out your ultrasound and think about this because it can definitely take a while to get an X-ray. Like if you just like listen to their lung sounds, they don't sound bad. It's not a obvious like COPD or asthma exacerbation. Like you could do a blue protocol with the ultrasound like 4 times over by the time it takes for like X-ray to get there.
I was going to ask you,
Yeah.
if you got the story, the physical exam, and these images, and you're sure it's a pneumonia, would you still do the X-ray in the ED?
No, not necessarily. I mean, I will say like it's like common practice to do one, partially because it's like very easy and like this is more of like a management question. Like sometimes it's, everyone comes in, like they come through triage, they get like their advanced triage, and part of their like advanced triage for like whatever sick symptoms they have are like getting a chest X-ray. That's almost like a workflow issue. But It's not necessary. This is actually more sensitive for finding a pneumonia. Like ultrasound is more sensitive to finding pneumonia than chest X-ray. And actually, it's kind of interesting. Like the patient population, you'd be more concerned about a pneumonia in. So like the elderly patients, like the ones who you would actually be want to like admit and like watch closely because the likelihood of them dying from pneumonia is much higher. Finding a pneumonia on chest X-ray becomes less sensitive as patients get older, while ultrasound like remains like a really good tool. It's just the fact that like performing like a true like pulmonary ultrasound, not even just like the 3-point one where you're looking like anterior, lateral, and like lateral inferior, but if you like do one where like the patient's sitting up and you're looking at like a 12-point exam, like you're looking 6 points on each side, it takes time. So that's why it's not always done. But honestly, like if you're concerned for pneumonia, and you're not seeing it on X-ray, feel free to do ultrasound and like use the ultrasound as your like diagnosis, as your like definitive like diagnostic to give your diagnosis for sure.
Okay, thank you.
Yeah. But again, this is Blue Protocol. Feel free to do it. It is a great protocol. It's a great like framework for pulmonary ultrasound. There's a lot more stuff we can get into with like thoracic ultrasound, but this is like a really good framework. That's it. Do you guys have any other questions?